Hi, this is Brian Kim. I'm going to share with you case number 114 in the Best Way to Do Cataract Surgery series. This is a giant sized pupil, but there's also some zonular laxity. And because it's such a big pupil, you'll be able to see beautiful anatomy to illustrate the double chop and cross chop technique. Again, when I do the technique, I'm not on top of the capsular bag. Therefore, it's not going to cause any zonular damage. You're not going to rip the bag. And the key is to make sure all your maneuvers are within the bag. And you'll be able to see that here with this really, really large pupil. So I'm going to use a cotton tip to steady the eye. And then I'm using a corneal marker, which will help me to center and size a Rexus. Using the same cotton tip, I control the eye for my paracentesis incision, first on the right side and then the left side, making sure I'm flat and parallel to the iris plane, which will create a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is some intracameral lidocaine, and then some dispersive viscoelastic to fill the anterior chamber. And using the cannula, the same cannula, I'm going to hold the eye for the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and when I'm ready, then I use a cannula to turn the eye towards me, which will allow me to enter the eye. Fill the eye with some more viscoelastic, and this is the puncture style Rexus. There's quite a bit of laxity, so let's see if I'm able to puncture with the technique here. So yeah, I was not able to because of the zonular laxity. When these high myopes and big pupils come in, there can be quite a bit of laxity here. So after I did that, rather than perseverating, I just go ahead and ask for the cystotome. So here's the cystotome. I'm going to go ahead and puncture the center and cut towards the left, which will create a flap on the right side. And I'm using the cystotome to create that flap. So switch back to the forceps now, grabbing that part of the tear, going around circumferentially. Again, this is a very large pupil, and so the corneal mark is very important because it helps you size the Rexus. With a huge pupil, you may be tempted to make the Rexus really large because the pupil size can deceive you. It's almost like an optical illusion. And so having the corneal mark really helps with the size and centration of the Rexus to accommodate the lens. See, the pupil is always a different size, but the lens is obviously always the same diameter, 6 millimeters. So that's why marking the cornea makes sense. So this is the capsular fornix hydrodissection technique. I place a cannula under the Rexus edge, contra-incisionally, point the tip down, get a nice wave, decompress on the left side, and then spinning the lens from the right. You can see it's already very loose. Try to do a little hydrodelineation there as well, tapping on the lens and then coming out. Irrigate the surface of the eye, adjusting the sleeve, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. You'll be able to see the placement of the instruments here, placing the chopper under the Rexus edge, contra-incisionally, the figure tip vertically, sub-incisionally, crushing and dividing the lens in half, placing the chopper around the right heminucleus and pulling it towards the figure tip, and that divides the lens. You can see that happens really so fast, and that's because I've just have so much experience with this technique. But if you go back and watch the video again, you'll be able to see I didn't have to place the instruments all the way to the capsule. I only went to the endonuclear epinuclear interface. So go ahead and remove that first quadrant, and then using the chopper to hook that second quadrant up, lifting it up, and then emulsifying the lens piece. So there's no reason to be scared. You're not actually going up to the capsule with the instruments. You just have to go right up to the endonucleus. Even if you get closer to the capsule, you're going to chop through epinucleus and it's soft. Again, the key is to be able to crush the endonucleus. That's the thing that really needs to be fractured. In this case, the epinucleus is soft, like in most cases. So go ahead and prolapse the epinucleus out with the vacuum, keeping the chopper deep. So I take the chopper out, push BSS in, take the phaco tip out, and go in with the iony handpiece. Start subincisionally, grabbing the anterior cortical material, teasing it out, using vacuum. You always want to grab the material, get a little bit of vacuum and some purchase, and then tease it off. This machine, the vacuum is so strong, I don't have to really sweep side to side like I used to with some of these other phaco machines. And so this is kind of a really a beautiful machine that really you can have great control, linear control with your foot pedal. So Cortex is out, switch to polish mode, polishing underneath the Rexus edge. Again, this is such a huge pupil, and you have to be mindful that there might be some zonular laxity. You don't want to stress the zonules while you're doing your maneuvers. That's why the polish mode is so nice. The very low numbers in the settings, low aspiration, low vacuum, just make it so safe. You're not going to accidentally grab the capsular bag and rip the zonules with this mode. So I'm polishing under the Rexus edge, polishing the posterior capsule surface as well. I'm going to pulse some BSS into the subincisional capsule fornix, which was nice and clean. Filling the bag with cohesive viscoelastic. And then I'm going to go ahead and sweep underneath the Rexus edge to remove any remaining lens epithelial cells. You can see I had to basically dump that entire viscoelastic tube in the eye, such a big eye. Placing the single piece acrylic lens into the capsular bag. The leading edge goes within the bag. While the lens unfolds, I quickly transition to IA. I go in with irrigation off, activating irrigation, making sure both haptics are released from the optic, going underneath the lens, tilting it and rotating it 90 degrees, removing all the viscoelastic from within the bag. Repositing the lens back, polishing underneath the Rexus edge, rotating the lens, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a really big pupil, some zonular laxity. You're able to see the anatomy so well, and as a result, you're able to see the double chop and cross chop maneuvers very clearly. Again, I did the case in real speed. You could see the moves are so fast, it's hard for me to talk fast enough to explain what's going on. But essentially, just remember the instruments are going up to the epinuclear endonuclear interface. You don't have to go to the capsular bag or to the fornix, so it's very safe. The instruments are brought together to crush the lens. So, you know, people think, oh, when you bring the instruments together, you must be pushing down on the zonules or pushing down on the lens. And the answer is no. If you understand what you're doing, the epinuclear material is soft. So when you bring the instruments around the lens, you're just getting around the peripheral soft lens material. When you bring the instruments together, there's no up and down movement of the lens or the zonules or the instruments. So then it crushes the lens completely in half. And because of that control, and again, I like to use the example of chopsticks. when you use a chopsticks to grab food, it's not like the food slips out from underneath the grip of the chopsticks. No, once you have a grip of it, you're able to control the piece of food. And then if you really wanted to, if it's a soft piece of food, you can literally crush the food piece with the instruments. And that's really the same principle when it comes to double chop technique. You're able to crush the lens piece and immediately have the piece controllable. You don't have to spin the lens and try to get the lens piece out through that small Rexus size, and just break the lens down into smaller and smaller pieces without having to use too much ultrasonic energy or high vacuum. And as a result, you have safer results as well as more efficient lens removal, and you can use less ultrasonic energy. And as a result, I feel safer surgery, and again, clearer corneas postoperatively. You'll have a happier patients, a more wow experience for the patients, but also a more wow experience for the surgeon. So I hope this was helpful to you, and I thank you for your attention.